Hi, everybody, and welcome to our module on obstructive lung disease. In the module on pulmonary function testing, I discussed the differences between obstructive and restrictive disease in terms of lung volumes and PFTs. But let me just highlight a couple of the key points here. In obstructive disease, you have air trapped inside the lungs because it can't get out. You also have slow flow of air going out and therefore less air going out in total. This means that you're going to have a reduced forced expiratory volume in the first second, and this is because of that slow flow out due to obstruction. You also have a reduced forced vital capacity because there's less air that you're pushing out with each breath. And then the hallmark of obstructive disease is a reduced FEV1 to FVC because the FEV1 falls more than the FVC so that this ratio gets lower. One other point before I go on to discuss specific causes of obstructive lung disease, and that point is on residual volume and total lung volume or total lung capacity. We don't normally measure these because they're very difficult to determine clinically, but if you were to measure them, you'd find that both go up in obstructive disease, and this is from air trapping. You can think of the lungs as a big balloon and the whole bronchial tree as the outlet of that balloon. And if you get an obstruction to outflow, this means that with each exhalation, less air goes out. So slowly over time, volume builds up and that balloon gets bigger and bigger. This means you have a bigger residual volume left in the lung at the end of each breath. It also means you have an increased total lung capacity, and that's sometimes confusing. You think with lung disease you'd have less lung capacity, but you actually have more in obstructive disease even though less is going out with each breath, and make sure that's clear in your mind. The opposite of this is true in restrictive disease. Both of these numbers fall in restrictive disease, and that's because there's a restriction, so that balloon of the lungs just can't fill as much to bring air in, and therefore if you were to measure the total capacity, you'd find it's smaller than normal, and the residual volume is also smaller than normal. Now we're going to talk about specific causes of obstructive lung diseases, and there are 4 that you need to know, and those 4 are chronic bronchitis, emphysema, asthma, and bronchiectasis. And we'll talk about all 4 of these disorders in detail in this video, but one thing I want to emphasize is that the key way these disorders are differentiated from one another is by the response to bronchodilators. Patients develop obstructive pulmonary function test findings in all 4 of these disorders, and so when a patient has obstructive PFTs, the next thing you want to do is administer a bronchodilator like albuterol. If the pulmonary function testing improves, then the patient has asthma, because of these disorders, only asthma is reversible. If the patient has no improvement in PFTs after administration of a bronchodilator, then that patient has chronic lung disease, either chronic bronchitis or emphysema, which together are called COPD, or bronchiectasis. So first we'll talk about chronic bronchitis, and this condition has a completely clinical definition. It's an arbitrary clinical definition that was decided on years ago, but it's been used in clinical trials and it's always stuck, and we continue to define the disease this way. So to say that someone has chronic bronchitis, they have to have a chronic cough that's productive of sputum for at least 3 months over 2 years with no other cause of cough present. And you should know that chronic bronchitis, like other forms of obstructive lung disease we'll talk about, is strongly associated with smoking. Patients with chronic bronchitis develop hypertrophy of the mucus-secreting glands in the respiratory tree. And this can actually be quantified by something known as the Reed index. This is usually determined in patients who die who have had chronic bronchitis, but post-mortem you can examine the wall of the respiratory tree, and you can determine the ratio of the thickness of the mucus-secreting glands to the thickness of the entire wall. That's called the Reed index. Normally, it's less than 0.4. In patients who have chronic bronchitis, it can be as high as 50% or more. And that's because these glands are hypertrophied and producing more mucus than normal. In addition, because of hypertrophy of mucus glands, the lungs can plug up with mucus. This is called mucus plugging, and this can cut off ventilation to portions of the lung. Also, the excessive amounts of mucus often impair mucociliary clearance in the lungs, and that raises the risk of infection. Infection is a common problem in patients who have chronic bronchitis. So the physiologic consequences of chronic bronchitis are that you have poor ventilation of the lungs. This means the level of carbon dioxide will rise in the blood and the level of oxygen will fall. Because you have a low level of oxygen, you can get hypoxic vasoconstriction in the lungs, and this can lead to pulmonary hypertension, and if it's untreated, it can eventually lead to right heart failure from cor pulmonale. Signs and symptoms you can see in someone with chronic bronchitis are cough from all that phlegm, wheezing from the airway obstruction, crackles from the extra mucus, dyspnea from the poor ventilation, and then finally, you can see cyanosis from shunting. Let me discuss shunting in a little more detail. I discussed this at length in some of the physiology modules. To understand shunting, let's consider a situation where we have two alveoli, one on the left side of the screen right here, and one on the right side of the screen right here. And both alveoli have an associated capillary that's carrying blood past the alveolus to pick up oxygen. Now let's assume that this alveolus on the left becomes plugged with mucus from chronic bronchitis, and therefore it does not fill with air and oxygen. What's going to happen in this situation is blood will flow past the alveolus that's healthy and become 99% saturated with oxygen. Blood that flows past the alveolus on the left does not become 99% saturated. It becomes hypoxemic. Its concentration of oxygen may get so low that it may even be about 60% saturated, which is what venous blood can be. The result is when the two streams mix, you get hypoxemia, and that is the mechanism of shunting causing hypoxemia, and that's what happens in chronic bronchitis. Now you should note here that if you were to give this patient 100% oxygen, it would not help. The blood on the right side of the screen here is already maximally saturated with oxygen. It can't pick up anymore. And the blood on the left side of the screen here is not flowing past a working alveolus to pick up any O2. Now, in reality, we give oxygen to patients with chronic bronchitis all the time, and it does help. However, you should know that the more shunt physiology that they have, the less the oxygen helps. Shunting is really a theoretical mechanism of what's going on at the alveolus level. It can be going on to various degrees in any particular patient who has chronic bronchitis. The next cause of obstructive lung disease we'll discuss is emphysema. So in emphysema, you get tissue destruction inside the alveoli. So why does this happen? Well, a very important concept for you to understand is that at all times inside your lungs, there is a balance between two groups of enzymes. One group is called the proteases, and the other is called the antiproteases. And when these are in healthy balance, you get healthy lungs without tissue destruction. However, if you get too many proteases or too few antiproteases, you will begin to have destruction of the alveoli, and that's what happens in emphysema. So the most common type of emphysema is a type we see in smokers. The smoke creates proteases, and these overwhelm the antiproteases, and as a result, the lungs get damaged. And the damage that occurs in smokers' emphysema is predominantly in the upper lobes. And an easy way to remember this is to just think of smoke rising up to the upper lobes of the lungs. The second type of emphysema is very rare. It's in patients who have a rare condition called antitrypsin deficiency. They have ineffective antiproteases, and as a result, they get emphysema, and their emphysema is predominantly in the lower lobes. We'll talk more about that in a few slides. So as I said, in emphysema, you get destruction of the alveoli. In the more common type, the smoker's type, the smoke activates macrophages. This leads to recruitment of neutrophils, and then you get production and release of proteases, which overwhelm the antiproteases. When you lose alveoli, you lose the elastic recoil of the lungs, and this is what leads to obstruction. This is going to cause the small airways to collapse when you exhale and air to get trapped in the lungs. This is easier to understand with a picture, so let's draw a little bronchus and then an alveoli here. So when you exhale, there are forces pushing down on this bronchus, but it remains open because there is some elastic recoil of the alveoli here. When the alveoli get destroyed in emphysema, you lose that elastic recoil. As a result, when you exhale, the bronchus is going to collapse and you're going to get air left behind and trapped inside here. And this leads to the physiology of obstructive lung disease. The clinical findings of emphysema are dyspnea and cough, much like chronic bronchitis, although there tends to be less sputum than chronic bronchitis. There's hyperventilation. Because those alveoli are destroyed, there's less area for gas exchange, so the patient will hyperventilate to try and get the remaining functional alveoli to do more work and keep the oxygen level up. Because of the hyperventilation, patients can lose weight, they're burning more energy and more calories, and then over time the hypoxia can lead to cor pulmonale and heart failure. And another classic finding of emphysema is the barrel chest. This is an X-ray of someone with a barrel chest over here on the right, and that's from all the air trapping due to the emphysema and the obstructive physiology. Let me review an important term for understanding emphysema, and that's called the acinus. This is a word that means berry, and the acinus in the lungs is the bronchiole plus an alveoli, so this is an example of one right here. Smokers who get emphysema get centri-acinar damage, so they tend to have damage to sort of the branch portion here and less damage to the alveoli. Patients who have antitrypsin deficiency get what's called pan-acinar damage, so they tend to have damage to this entire structure here, and it's very high yield to know that smokers get centri-acinar, it's sometimes called centrilobular damage, and antitrypsin patients get pan-acinar or panlobular damage. In the top left here is a tissue specimen of a patient with emphysema, and the key findings are that there are big white spaces and that there's lots of white space here. In addition, the septa between the air spaces is very thin compared to normal, and thin septa and large air spaces are the findings in emphysema. Down here on the left is an example of a smoker's lung. They have these black spots, which are sometimes called dirty holes, and those are evidence of central lobular damage from smoking. And then over here on the right is another example of hyperinflated lungs in a patient who has emphysema. To help you better understand the concept of the barrel chest, let's review this graph of chest volumes and pressures, and I go over this at length in some of the other physiology modules. But for our purposes here, recall that the FRC is the functional residual capacity. That's the volume that the lungs settle on after a quiet breath. And it's the point where this green line crosses the zero pressure mark. And at the FRC, the pressures and forces in the lungs are balanced so that the tendency of the chest wall to expand outwards is balanced by the tendency of the lungs to collapse inwards. In patients with emphysema, the blue line for the lungs changes to look like this. This means that the FRC is going to move up. The point where those forces are going to be balanced is now higher up. Thus, you have a higher volume at the end of a quiet breath, and that's why you get the barrel chest. That's the visual representation on this chart of the air trapping that occurs in emphysema. There's a classic description of the different appearances of patients with chronic bronchitis versus emphysema that you should know, and this is called the blue bloater and the pink puffer. So patients with chronic bronchitis are called the blue bloaters. They have cyanosis from that shunting mechanism I described, and this makes them blue, and then they have air trapped, and this makes them bloated. Patients with emphysema, on the other hand, are the pink puffers. They've lost alveoli, so they've lost surface area for oxygen absorption, so they're hyperventilating to compensate. This is why they're puffers. And initially, this maintains their O2 level and makes them pink. Now, in reality, this classification isn't of that much value because most patients have some elements of both, but you should be aware of this classic description. COPD stands for chronic obstructive pulmonary disease, and this is the term we use in the modern era to describe patients who have chronic bronchitis or emphysema. Both chronic bronchitis and emphysema are associated with smoking, and rarely do patients have symptoms and signs only of chronic bronchitis or only of emphysema. Almost always, patients who have one of these disorders also has elements of the other, and therefore we refer to the two conditions as chronic obstructive pulmonary disease. Now, in general, asthma is a separate disorder of COPD. There's only one exception. Patients who have very severe asthma that does not reverse between exacerbations are considered to have a version of COPD. Most patients with asthma do not have COPD, but if asthma is left untreated, eventually it becomes a chronic disorder, and then it is called COPD. And the reason we lump these disorders together, like chronic bronchitis and emphysema and severe refractory asthma, is because many of the symptoms are similar, like cough, dyspnea, and wheezing, and many of the treatments are similar. And therefore, we talk about all these disorders in the modern era as being under the heading of COPD. Next, let's discuss alpha-1 antitrypsin deficiency. So recall that most emphysema comes from smoking, but there is a very rare form caused by deficiency of antitrypsins. This is an inherited disease, and people who have this condition have decreased or dysfunctional antitrypsins. And remember that the antitrypsins balance the naturally occurring proteases in the lungs. The most important of these is elastase, which is found in neutrophils and alveolar macrophages, and it's always present to a small degree in the lungs. As long as you have antitrypsin around, it won't cause any damage, but if you lose your antitrypsin, then it can cause lung damage. People with this condition get problems in both the lung and the liver. So in the lungs, they get pan-acinar emphysema. And remember, that's different from smoker's emphysema, which is centri-acinar. They have an imbalance between neutrophil elastase, which destroys elastin, and the antitrypsin, which protects the elastin. And as a result, they get lower lung damage. And remember, this is also different from smokers who get upper lung damage. A second problem people with antitrypsin deficiency have is liver cirrhosis. So abnormal alpha-1 can build up in the liver. This is only going to occur in certain subtypes of this disease where people get polymerization of the antitrypsin in the hepatocytes, and it leads to hepatocyte death. So there are some patients who have severe antitrypsin deficiency with lung problems but no hepatocyte accumulation. But you definitely should know, and it's high yield for step 1 to know that the liver can be involved from polymerization of the antitrypsin in the hepatocytes. So the classic case of antitrypsin deficiency you should know for your boards is a patient with typical COPD symptoms like cough and sputum and wheezing, but usually they're relatively young. So most patients who get COPD from smoking are in their 60s or 70s. This will be someone who's in their 40s or maybe even younger. On imaging, there'll be emphysematous changes that are most prominent at the base, and on pulmonary function testing, they'll have obstructive physiology. And the question often asks about pan-acinar involvement, so make sure you remember that. And then one thing to know about antitrypsin deficiency is these patients should never smoke. So they have no antitrypsin activity. So the last thing they want to do is smoke and stimulate the neutrophil elastin